talk about some of our work with the anti-EGFr antibody cetuximab and how this has evolved over the years in the treatment of squamous cell carcinoma of the head and neck. During the 80s and 90s, the primary treatment for local regionally advanced head and neck cancer was radiation treatment. And that persisted for many years, and so there was a great push to look for new agents in this field. The anti-EGFr agents became of interest when it was discovered that head and neck tumors almost universally overexpress epidermal growth factor receptor. This receptor is known to promote tumor cell proliferation, tumor cell angiogenesis, and also enhance survival of tumor cells through pathways such as the JAK-STAT pathway, which is a pathway that inhibits natural apoptosis, and we'll talk more about that at the very end. So this pathway was prominent in tumor cell growth. Additionally, many investigators in the 90s, this is a trial from the 90s that Dr. Hang and MD Anderson looked at in 2002, showed that epidermal growth factor receptor, high levels of epidermal growth factor receptor correlated with decreased survival. Also decreased disease-free survival. Additionally, it was discovered that high levels of epidermal growth factor receptor correlated with increased local failure. But surprisingly, this was not correlated with distant failure. So this led investigators, is that little squealing noise bothering you all at all? I can hear it up here, I'm not sure if you can hear it. This led investigators to believe that perhaps inhibition of epidermal growth factor receptor may help us improve the effects of radiation, because all of these patients are treated with radiation, and the ones with the high EGFR levels still failed the radiation. So the hypothesis was that if it could inhibit EGFR, we may enhance that local regional effect. So there are multiple ways to inhibit epidermal growth factor receptor. One can use monoclonal antibodies such as cetuximab or panitumumab, which bind to the ligand binding domain where EGF binds to EGFR, or you can use small molecule inhibitors such as erlotinib or gefitinib, which bind to the kinase domain of the receptor and block downstream signaling. At UAB in the mid-90s, we performed a phase 2 trial of patients with local regionally advanced, unresectable squamous cell cancer. These are large, local regional tumors that could not be resected. And we had 15 patients, and we treated them with radiation and cetuximab. That's the arm up here, alone. It was a phase 1b/2a trial. We had only 15 patients on that trial. 13 patients had a complete response, 2 partial responses, and one of the partial responses was converted to a complete response after neck dissection. So we took that information to the FDA in 1998, and I presented that to the FDA, and they allowed us to go forward with this randomized trial based upon a phase 1/2a trial of 15 patients. Probably wouldn't happen today, but we moved forward with this trial, taking the UAB regimen of cetuximab and radiation versus radiation alone, and we stratified by T-stage, N-stage, the fractionation regimen utilized, and performance status. What did we find? This was reported in the New England Journal of Medicine in 2006. We found that the addition of cetuximab to radiation resulted in an improvement in survival that was statistically significant, 3-year improvement in survival, or in local regional control, from 34% to 47%, an absolute improvement of 13% in local regional control. This is survival. Cetuximab resulted in an improvement in overall survival, 3-year improvement from 45 to 55%, so an absolute improvement in survival of 10%. This changed the landscape of head and neck treatment throughout the world. Whenever you implement a new radiosensitizer, you're concerned about whether that radiosensitizer impacts the effects on normal tissue. And many radiosensitizers have gone by the wayside because they sensitize normal tissues more than tumor tissue. So we looked at the most debilitating side effects of radiation treatment, mucositis and dysphagia. And this is grade 3-4 mucositis dysphagia. One can see that cetuximab in red did not enhance the onset of grade 3-4 mucositis compared to radiation alone in blue, and did not prolong mucositis, grade 3-4 mucositis compared to radiation alone. Same was true with grade 3-4 dysphagia and onset and resolution. So that was very encouraging that cetuximab had no effect on the most debilitating side effects of radiation. Cetuximab does cause an acneiform rash, which does not seem to inhibit the delivery of radiation therapy unless you're not used to dealing with it, and it's very surprising because it can be a very prominent acneiform rash. We found in this Lancet Oncology paper in 2010 that the acneiform rash is a good thing with respect to overall survival. Those patients that achieve an acneiform rash, out of all the patients that undergo cetuximab treatment, none of the radiation alone patients are included here. So all cetuximab patients, but the ones that have the rash do much better. Very prominent finding. If you are going to achieve a rash, usually it's within the first 2 to 3 weeks. So I'm always kind of happy when my patients have that rash, even though it's not the most pleasant thing for them. I feel encouraged they're going to do better. Well, at the same time that we were investigating the addition of cetuximab to radiation in local regionally advanced squamous cell cancer, many others were investigating the addition of chemotherapy to radiation in local regionally advanced head and neck cancer. And during that time period, from when we started our trial in '98 and finished in 2002, many chemotherapy trials were done, and chemotherapy became a prominent standard of care for these patients. So the next question arose. We designed this trial in 2005, Radiation Therapy Oncology Group 0522, in which we looked at one of the standards of treatment, radiotherapy and cisplatin, and we added cetuximab to that regimen in a randomized fashion. So radiotherapy and cisplatin plus or minus cetuximab. What did we find? No addition of no improvement in local regional control, progression-free survival, or overall survival for the addition of cetuximab to chemoradiotherapy. So does that mean that there's not a good method of integrating both chemotherapy and cetuximab with radiation? Not necessarily. I think there are some very exciting things happening with taking chemoradiotherapy and still considering best ways of adding cetuximab. This is one trial from the French group that was published just a couple of years ago. It's called the Kremlin study. Patients received TPF induction chemotherapy, and then were randomized to cisplatin and radiation versus cetuximab and radiation. This is the laryngeal preservation trial, so larynx cancer patients were entered. It's a fairly small study, but it gives us food for thought. And what they found is that laryngeal preservation was not different between the two arms of cisplatin radiation and cetuximab radiation, and overall survival was not different. However, there were some differences in toxicity. Patients that received cisplatin had a higher rate of renal toxicity, as you can see here, suggestion of higher subcutaneous fibrosis and other side effects. So I think this demonstrates that there are ways that we can improve treatment by continuing to explore new methods of integrating chemoradiotherapy with biologics. And they don't all have to be given in one fell swoop. We can change the timing of when we deliver these agents to optimize the therapeutic index. Kremlin study again showing the difference, the lack of difference between cetuximab and radiation versus cisplatin and radiation. Now during the same time frame when we were running our radiation plus or minus cetuximab trial, HPV became a known factor in head and neck cancer. So it's really hard to talk about head and neck cancer over the last 10 years without mentioning HPV infection. And so our trial was designed in 1998. We did not know about HPV's role in head and neck cancer at that time, so we did not test we did not write into the protocol to test for HPV status. So briefly, let's look at the significance of HPV in head and neck cancer. And one great way of doing that is to take a large negative trial and look back at biological markers. This was RTOG 0129, started in 2001. It was a trial of 721 patients, randomizing to standard radiation with cisplatin versus altered fractionation with cisplatin. No difference in overall survival or progression-free survival, but that's not the point I would like to make. I want to take these 710 patients and look at the significance of HPV. And one can see strong prognostic significance of HPV positivity in this group versus HPV negative patients. Dr. Ang went on to perform a recursive partitioning analysis in which he identified a low-risk population, intermediate population, and a high-risk population based upon HPV status and past years of smoking, end stage, and T stage. All those factors were incorporated into this recursive partitioning analysis, which resulted in a prominent risk identification process. The low-risk survival shown here, intermediate, and high risk, which can be utilized for future trials. Back to our study of radiation plus or minus cetuximab. Even though we hadn't tested for HPV, investigators across the world started saying cetuximab works better in HPV positive patients, because when we look at the trial that I published, we see that patients with oropharynx cancer benefited most from cetuximab. This is all a retrospective look, of course. Patients with high Karnofsky status benefited and low age. Those are all factors one would associate with HPV positivity. So it started becoming a dogma that cetuximab probably works best in HPV positive patients. Well, we were able to get permission from the NIH Central IRB to go back and look at HPV status in our trial, even though we hadn't written the trial in that manner from the beginning. So we presented this at ESMO just last fall in Madrid, and this was the Association of Human Papillomavirus Status and Efficacy and Safety in Patients with Oropharynx Cancer in a phase 3 trial of radiotherapy plus or minus cetuximab. We used P16 immunohistochemistry. I'll try to speed up here a little bit. We looked at local regional control, progression-free survival, and overall survival. We used Cox proportional hazards to compare treatment arms. We also used log-log plots and Schoenfeld residuals to make tests for interactions of variables. The P16 positive and P16 negative groups in this trial had fairly similar characteristics, and due to lack of time, I won't go into that. But this reminds you of the RTOG trial I just showed previously. HPV positive patients did extremely well. HPV negative patients not so well with respect to overall survival when we went back and looked at our patients. But we were interested in seeing whether cetuximab functioned preferentially for either HPV positive patients or HPV negative patients, or if it were comparable for both groups. What we found is that in this patient population, this shows local regional control, and we discovered that the association of HPV status as assessed relative to cetuximab radiosensitivity showed that cetuximab resulted in improved local regional control for HPV negative patients as well as HPV positive patients. And the test for interaction showed no interaction between HPV status and cetuximab effect on local regional control. One could hypothesize that the benefit was slightly greater for the HPV positive patients, but that was not borne out by the interaction test. The same is true for overall survival. Cetuximab resulted in an improvement in overall survival for the HPV negative patients and the HPV positive patients. Again, one could hypothesize there's a slightly greater effect for the HPV positive patients, but it was not statistically significant when we tested for interaction. Now, moving on to the last aspect of this, we went on to then look at toxicities. Once again, we want to see if HPV status predicted for which patients may have more debilitating toxicities consisting of radiation-induced mucositis or dysphagia. Onset of mucositis was defined as the time without mucositis, and duration of mucositis or dysphagia, whichever we're looking at, was defined as time with mucositis or dysphagia still being present. And we found that if we look at all mucositis in P16 positive or P16 negative patients, there is no difference for adding cetuximab to radiation with respect to onset of mucositis or duration of mucositis. This was also true for all grades of dysphagia. P16 positive patients, P16 negative patients, the addition of cetuximab did not alter the onset or duration of dysphagia in P16 positive or P16 negative patients. So there was no interaction between the cetuximab side effects and HPV status. Same was true for grade 3-4 mucositis and grade 3-4 dysphagia. When we talk about epidermal growth factor receptor, we're talking about the tip of the iceberg. This is a protein that results in multiple signaling pathways that I mentioned earlier at the onset of the presentation. One that we're very interested in is the JAK-STAT pathway. This is a pathway that is stimulated by phosphorylation reactions from EGFR. When the JAK-STAT pathway is stimulated, it leads to protection from apoptosis, allows the tumor cell to continue to live. We are currently looking at several JAK-STAT inhibitors in our lab. This is apoptotic assessments of 4 different squamous cell cancers in our lab. And we found that this is cetuximab alone causing some apoptosis, JAK1 inhibitor alone causing minimal apoptosis, more in other cell lines. When you combine the two, you get marked increase in apoptosis from either of the agents alone. Then when you combine them with radiation, we see marked radiosensitization for the 2 radiosensitizers. So we're interested in knocking out more than one step in the signaling process. So that's the next generation of biological studies that we are looking to perform both in the lab and in the clinic. So in conclusion, we found that the addition of cetuximab to radiation resulted in an improvement in local regional control and overall survival for both resectable and unresectable squamous cell cancers of the head and neck. This was regardless of HPV status. Patients with P16 positive oropharyngeal cancers had a favorable prognosis. The addition of cetuximab to radiation did not alter the time to onset or duration of resolution of mucositis or dysphagia in patients with oropharyngeal cancer, irrespective of P16 status. And these present findings should be regarded as hypothesis generating and providing impetus for future studies with larger sample size. Thank you.